Hello everyone, this is about a 30-year-old lady who has been having recurrent headaches for almost a year. You can see three images. One is the CT head topo, the second one is the selected CT axial sections in brain and bone windows, and the third one is the transvaginal study images. I am giving three questions. What are all the findings in the CT brain? What are all the findings in the transvaginal study? And can you think about the associated syndrome? If you want more time, please pause the video and review with the given images. Within few seconds, I'll give you the findings, the diagnosis and the associated syndrome with short discussion. Are you ready? Let's go. CT reveals significant thickening of the inner aspects of the frontal bone with nodular sclerotic appearance, which is thicker to the right of midline and longer to the left side of midline. All these findings are suggestive of hyperostosis frontalis interna. The rest of the bony skull appears normal. Even the brain was unremarkable. The transvaginal ultrasound reveals bulky polycystic appearance of both the ovaries with thin endometrium, which is typical for polycystic ovarian morphology sonographically. Now I will give you the additional clinical history that she has a 4-year-old child and she is gaining a lot of weight with irregular oligomenorrhea. She has been having headache which is progressively increasing by the intensity, and it is persistent for a longer time nowadays with 3 months of amenorrhea now. The investigations revealed elevated testosterone with rest of the hormonal analysis, which is highly supportive of polycystic ovarian syndrome. The combination of hyperostosis frontalis interna and PCOS is highly suggestive of Morgagni-Morrell-Stewart syndrome. There are so many synonyms for this, and please go through the picture to know about the other names. Now we will go for the discussion. Hyperostosis frontalis interna is a benign osteopathic condition noticed in the perimenopausal women due to the hormonal imbalance. It is most common in the frontal bones, as the name says, but it can extend less commonly to parietal bones too, which can be called as hyperostosis frontoparietalis interna. It is said that it never affects the temporal bones, and if it affects the temporal bones or the skull base, it could be due to either hyperostosis cranialis interna or due to other causes. The hyperostosis cranialis interna is a unique autosomal dominant sclerosing bone dysplasia. It affects the entire cranium, even the skull base. It most of the times presents with the symptoms of cranial nerve deficits due to the narrowing of the intracranial foramina compressing the cranial nerves, whereas the hyperostosis frontalis interna doesn't do that. When we go for differential diagnosis, there is a long list. More common ones, the meningioma and fibrous dysplasia and the breast and prostate malignancies. Less common ones are also listed for completion's sake. Please go through it. Now we will discuss about our case. There has been 4 grades of hyperostosis frontalis interna till 2010. Now it has been modified to 5 grades now from 2011. Please go through it. Our case fits in for the type C category with the sclerosis affecting almost 50% of the frontal bone because it gives the prognosis and might be helpful for the management too. We will discuss about the subfertile women with Morgagni syndrome. Presence of Morgagni syndrome in a subfertile woman significantly diminishes the fertility rate and the probability even after good diet or medical or surgical management, especially with type D and type E of hyperostosis frontalis interna, where it is diffuse, involving major portion of the frontal bone. In my knowledge, there is so much debate and articles and literatures about very common polycystic syndrome, but there is no much debate or articles or literature to give the proper guidelines for Morgagni syndrome, thinking that it is rare, but the actual truth that it is rarely diagnosed clinically and also through the imaging wise in the background of highly alarming fast progression of PCOS now, because nowadays polycystic ovaries has become a very casual diagnosis clinically and by imaging too. In this 2022, it becomes more important with increasing incidence of myocardial infarction in females too, and there is shooting up incidence of breast malignancies, and the infertility has been raising more than the incidence of myocardial infarction and breast malignancies. Common people know that the silent killers in men, many people don't know about the silent killers in women. Think about the chess now, which is a worldwide popular in board games. In females, if diabetes or ischemic heart disease becomes the king, and the breast malignancy becomes the queen, and where is our PCOS? Please think. Yes, you are right. PCOS is the chessboard where the king and queen are living. So I'll conclude that the polycystic ovarian syndrome is also a very notorious silent killer now. So dear doctors, take care of yourself. Health is always wealth.